we don't see a particular family history. So we've talked about once we can get the price of testing down low enough, once we can know how to interpret the information well enough and quickly enough to even have something like a $100 test that would think about your history or look at your risk factors, genetic risk factors for breast cancer, ovarian cancer, uterine cancer, colon cancer, even familial hypercholesterolemia or heart attacks, but being able to do that. And so there are some pilot studies that are being done right now in California to actually see how well that works, how scalable that is, and at some point we'll have to decide. It's still going to be an individual choice, but whether or not both men and women would be included within that and how much we can do in terms of improving health. So watch for that. My prediction is within the next 5 years, that's going to actually be a thing in terms of a large number of people, both having that as an affordable, accessible way to think about keeping themselves healthy.
Yes, I have two questions, one related to me and one related to my daughter. Mm-hmm. I was BRCA positive and I went through ovarian, surgery and chemotherapy and everything. So do you think I need to do the rest of the thing now?
What is the rest of the thing that you mean?
You said, even if you've had the BRCA testing, but beyond that,
the other genes.
Yeah.
I think probably we could talk offline, but I think you've probably found your answer already. So I think you're probably good as you are. I think you probably don't need the additional testing I talked about.
Okay, and the other thing is about my daughter. She had a testing done when she was 40 and it was negative, but now she's 52. You think she might want to go for another testing now? Because we have a very, very bad history of breast cancer and leukemia and all that on both sides of the family.
Yeah. So for anyone in the group or anyone who knows of someone who already has a mutation identified in one of these genes, what we usually do is we sit down with you and figure out if that mutation seems to explain the cancers in the people in the family who had cancer. Most families do not have two genes. And so for most people, one is enough. And my guess is in your family, probably that one explains it. For other family members that then get tested for that specific gene, if it's negative once, it will be negative forever. It's not going to change. They are simply done. And so for your daughter, the good news is even though she's your daughter, she doesn't have this gene from you, and so she is not going to be at any higher risk than if we go out here on the street and pull someone off the street, no higher risk of breast cancer, uterus cancer, anything else than anyone else should have.
Okay, thank you very much.
I'd like to know the other genes that you had indicated that we should look for, that young people should look for?
Yeah, so I'm glad to rattle them off to you. They might not make too much sense, but MSH2, MLL1, PMS2 are some of the genes that we do in terms of these Lynch syndrome genes for breast cancer. There are things like P10, P53, PALB2. It sounds like, someone once told me, it sounds like you're from Star Wars. It sounds like R2-D2 to me in terms of all of this. So anyway, there's a lot of mumbo jumbo in that. The bottom line is that you can, even if you just Google, and I'm not here representing any company in terms of doing it, but if you Google, there are 3 laboratories that offer, I think, or maybe 4 laboratories that offer some good testing. So you can look at Myriad, Color, Ambry, GeneDx. All 4 of those laboratories are very good, robust genetic testing laboratories, and all of them have very good patient-facing materials for patient education. And again, I'm not pushing any one of the laboratories, look and see what works well for you.
Hi, my mother had eye cancer, which is very rare, and breast cancer, and I had breast cancer 30 years ago. What do I do, and how do I, with my family, my children, how do I go about taking care of all of this information?
Yeah, so a lot of what I said actually applies to you. I don't know if your mom had melanoma in terms of an eye cancer, ocular melanoma, or something else. There are some things that put those together, and again, your family, you in particular, would be a good person to do that expanded testing now. I will say one other thing I probably neglected to mention. The best person in the family to test is to start with testing someone who's had cancer themselves, because we're answering the question, why did you develop cancer? And then to use that information to other people in the family to help advise, are they at the same risk for cancer, just like you had your daughter tested. So you can talk with me afterwards, but if you get that expanded testing, that'll take care of it for your family.
Thank you.
Can I ask you a question? Hi. Well, it was a fabulous talk, and congratulations on what you've done. And I was totally behind you until you got through the bracket 2 section. And then I kind of wonder if another point of view I want to ask you, because I was a cancer researcher myself. I'm retired for some time now. But what's bothered me about this is that this precision medicine thing, even though the cost has come down, is far from cheap, right? And these other cancer genes, these low-level ones that you may know much more than I knew at the time I retired, but the risks from these things are small and population-wide very small, and the cost is enormous. So this is, in a way, a research project on a grand scale, which is terrific for the 1%. I call it medicine for the 10%. But, in this country, 50% of cancer deaths are preventable by proven methods. And so I sort of wonder, when it's a socioeconomic thing almost, is it reasonable to, because the precision medicine that's done on tumors, for example, all hospitals have to sequence every tumor, has produced almost no positive results. It turned out such a tiny fraction have actionable mutations, and such a tiny fraction of those respond to extend life and so forth. So I was very with you with the cost effectiveness and so forth, but cancer has become almost an industry.
Right.
And I question this level of precision for a reward that we're getting from it for the cost. And I'd just love to hear what you think about it.
Yeah. So I think there are two different questions embedded here, and I'm going to speak to you at a slightly higher level, and I apologize. Other folks tell me if I get too obtuse. So I'm going to first answer the question about heritable factors, so things that are coming in that you're at risk for. So let me be clear, when I was screaming, I promise I won't scream at you, but I was screaming out genetics. Those are the things that are very high risk, and there are now about 50 genes that we routinely screen for that are very high risk, that are not the sort of low risk things. The low risk things are things that truly are on a research basis at this point, but when you start aggregating not just one low risk, but now start aggregating many low risks and come up with something we call a polygenic risk score, that risk conferred, that composite risk conferred for those at the upper decile can be as high as the high risk genes. So within this, and I apologize in terms of being a little obtuse, but that is totally on a research basis right now, but the right now in 2 years becomes, current. And so I'm just trying to give you sort of foreshadowing of the things that are coming in the future, and some of you that don't have answers today, you may have answers tomorrow. I think that's the point that I was trying to make. Within this, I think the whole ability to make this cost effective, and I worry a lot about cost effectiveness, is to really be able to drive down the cost of sequencing and drive down the cost of interpretation. And just to give you one example of this with something that's not related to cancer at all, but for a different condition in babies, we actually have a policy, a way of being able to screen all newborn babies now in the United States for a specific genetic condition where it costs us 11 cents per baby. So there are ways, there are technologies to be able to drive down the cost in terms of the testing and scale them in terms of population health. And at the end of the day, that is something that I want to be able to do. And it's actually not just going to be cancer, but it's going to be population health in toto. And it is going to be way, way down from where we are now. So I'm with you. And I do think about our healthcare dollars a lot. And as I said, having just come back from China and realizing what you have to do from population health in now a population way, way bigger than even what we are in the United States, and do it equitably, we have to be able to do better than where we are now. That's for sure. The tumors are a bit different in terms of that, and I agree with you as well. I do think in terms of the tumor sequencing, and many of you seen this because like Sloan Kettering's been all over the news recently with some of this. It definitely is not at the point where it's providing hugely improved care, improved outcomes, things like that. There are a very small number of people who truly have a transformational approach, but it's a very small number at this point. I think the thing that becomes tough is trying to decide for yourself, am I going to be one of those 1 in 1,000 that's going to have something really important? And, I don't want to miss my opportunity is the situation I feel like people are in right now. On the other hand, I do think there are ways of being able to do very targeted testing, literally for a small number of dollars, like literally less than $20 in terms of the things that are actionable that make a huge difference, and be able to scale that for people with cancer. I think there's been a little bit of confusion between what's research and what's clinical care at this point. And institutions, large institutions, want to perform research on clinical care dollars, and I think that's where some of the confusion has come right now. So it's tough, and I appreciate everyone just wants the best for themselves and their patients, but it does get confusing.
We're going to take 2 more questions, so Monica and Mercedes, we can both find someone for the last questions.
Hi. I have metastatic breast cancer, and they did the testing on me with the original tissue, and then I recently had a recurrence, and they did more testing on that tissue. So how will that work with insurance? Because will they limit how many times they can do the genetic testing? Because obviously, I don't know if the mutations, they're different.
Right.
And I don't know what my future holds, so I didn't know if there becomes a limit on testing.
So with this, and I realize this is incredibly confusing, when we talk about genetic testing in the cancer, it's very different than when we talk in genetic testing for the whole person, right? So what's going on with genetic cancer or genetic testing in the cancer is the cancer can change over time. And in particular, the metastasis can change over time. And so you're chasing trying to figure out how that cancer is working and how to outsmart it. Insurance companies, if they're going to pay, they should pay for each time you need to because your cancer is changing and evolving. Now, whether or not insurance companies agree to continue doing that, that ends up being a policy decision that's way over my head. But in theory, that's a very different question from them in terms of, I had this panel of genes today and I want to have the same panel of genes tomorrow. That they should not pay for because your genes haven't changed for yourself over time, and that they will not continue to pay for again and again. But again, the cancer itself, that is evolving, that's changing, and there may be new things you find in a metastasis that you didn't find in the primary.
I am wondering if someone is to get this test and finds out that they are, I kind of have a 2-part question. So you find out you are genetically at risk for some kind of cancer. The benefit of knowing that is simply perhaps, am I missing anything that now I can start looking for it and screening, and if there's anything perhaps I can do, I could be doing it. And then conversely, if I don't come up with anything, does that mean, whew, I'm in the clear?
So 2 parts of the question. So if you do find out that you're at increased risk, the hope is that we can figure out very specifically what you're at increased risk for, when in your lifetime you're at increased risk for that, and then what can we do to minimize that risk, either because of screening, either because of medicines or surgeries in certain cases. But we can give you some advice that's now all about you in terms of that risk. When you come out negative, it's actually a 2-part question again. Part of it depends on not just you, but the rest of your family. So is anyone else in your family positive? The combination of them being positive and you being negative actually is a better thing for you because it means that you may not, just like this young lady here, your daughter didn't inherit your mutation. That means she's at lower risk, right? That situation ends up being better for your daughter in the sense that she doesn't have the cancer risk that you had. If no one in the family has come up with an answer, it lowers your risk because we know now many of the genes we can cross off the list, but it may not make your risk 0 or the average person because your family could have a mutation in a gene that we just haven't figured out yet. And so if there is still a family history of cancer that we can't explain, then we say your screening should be based on what we see in your family. So if we still see unexplained, if you will, colon cancer, we want to do the colonoscopies because that absolutely is something we can nip in the bud and we can prevent colon cancer in the future. Thank you.
Thank you very much, Dr. Chung. Thank you all so much for coming, and I hope you have a great day.